Welcome to this module on cardiovascular and respiratory emergencies. We're going to spend a few minutes talking about cardiovascular and respiratory emergencies and what you might see with urgent care patients coming in through the ER. These are two huge topics to discuss, and let's be honest, we could probably create two whole master courses just based on these topics alone. However, for today, we're simply going to review a couple of patient cases as they would present through the ER with respiratory changes and/or cardiovascular changes and discuss the initial workup steps and treatments you would pursue for both. We'll also spend a few moments at the end talking about different types of shock, how to identify them, and a few basic stabilization steps that you can take. Welcome to the Master Course on Urgent Care, brought to you by Kruuse. Picture this: Frankie, an 8-year-old male-neutered Pomeranian, presents to your clinic in severe respiratory distress after getting worked up and not being able to calm down following an impromptu visit by the mailman and a lot of barking. His panting respiratory rate is 90 to 100 breaths per minute, and his gums are cyanotic. On your primary survey, you appreciate that Frankie has an abnormal honking sound to his breathing on both inspiration and expiration. On thoracic auscultation with your stethoscope, you appreciate the heart rate to be approximately 120 beats per minute with no audible murmur, but his lungs are pretty loud, so you can't fully rule one out. Frankie has mild right-sided inspiratory crackles in his cranial-ventral lung fields. Other than being distressed, your brief survey of Frankie's neurologic status is pretty unremarkable. You provide some flow by oxygen, and Frankie's mucous membrane color improves a little bit, and he seems to be a little less distressed, enough that you can complete his secondary survey. You appreciate that Frankie has mild mid-abdominal discomfort, luxating patellas as every good Pomeranian does, and a little bit of soft stool on his rectal examination with some blood. Frankie is placed in an oxygen cage to calm down while you create a differential list and an initial diagnostic plan. You also take this time to talk to your nursing team, who gives you a background on Frankie's history. You find out that Frankie has a history of a goose-like honking cough at home that he's had for approximately 6 to 8 months. He's been becoming more and more agitated and worked up with every coughing episode, but today is the first day that he hasn't been able to completely calm down on his own. Frankie also had an episode of vomiting prior to getting worked up this morning. Now, based on Frankie's presentation and history, take a few moments to think about what Frankie's differential disease processes might be and what you might want to do as a clinician to work it up. As you might have guessed, Frankie's primary differential is tracheal collapse. However, as you cannot completely hear his heart and he has some inspiratory crackles, consideration should also be given to an underlying cardiomyopathy, aspiration, pneumonia, or pneumonitis, and non-cardiogenic pulmonary edema. This is a short but not exhaustive list of what could be going on with our friend Frankie. Based on these differentials, we want to further evaluate the pulmonary parenchyma as well as intrathoracic and cervical structures such as the trachea. Let's start with thoracic radiographs. For Frankie, we are first and foremost going to be looking at his trachea and pulmonary parenchyma on the X-ray. We see that he has tracheal collapse, or narrowing of the trachea, at the level of the thoracic inlet. This explains the honking noise that we heard on both inspiration and expiration, as patients with either cervical collapse, so above the thoracic inlet, or intrathoracic collapse, so below the thoracic inlet, tend to have inspiratory noise or expiratory noise, respectively. While radiographs are helpful for identifying the presence of tracheal collapse, they are not the most specific for identifying the severity of collapse. Rather, these patients need additional studies like bronchoscopy or fluoroscopy to further evaluate the severity of the collapse present, particularly if the owners are interested in tracheal stenting. We'll talk a little bit about that later. Frankie's radiographs also show the presence of mild pulmonary infiltrates in the right cranial and middle lung lobes. This means he's got some fluid in his alveoli down there. Based on his history of vomiting this morning and the presence of infiltrates in these regions, we have justifiable concern for aspiration of fluid into Frankie's lungs, which may have exacerbated his episode of respiratory distress and agitation when the mailman came. An additional benefit of chest x-rays is the ability to evaluate for the presence of cardiomegaly. We can look at something called the vertebral heart score to measure how big the heart actually is. We do this by taking a lateral thoracic radiograph with T4 through T12 vertebra clearly visible. From there, we want to measure the longest axis of the cardiac silhouette from the carina of the mainstem bronchus to the apex, and then transfer this measurement to the vertebra starting at the cranial edge of T4, and then counting the number of vertebrae that fall within that line. Next, we want to measure the short axis at the widest part of the cardiac silhouette, perpendicular to the long axis measurement, and then we transfer this short axis measurement to the vertebra starting at the cranial edge of T4, and again, counting the number of vertebrae that fall within the points. The sum of the two measurements equals the vertebral heart score. A normal range in dogs is 8.7 to 10.7, and a normal range in cats is 6.7 to 8.1. We can also look for things like increased cardiac sternal contact and rounding slash enlargement of heart chambers when evaluating for the presence of cardiomegaly. We can also evaluate chest wall conformation changes. For example, in cats with historic severe asthma, it's not totally uncommon to see rib fractures in episodes of severe respiratory distress. If we wanted to evaluate Frankie's crackles and pulmonary infiltrates further, we could consider a focused ultrasound examination on the right side of his chest. In Frankie's case, we'd likely see B lines, which coincide with alveolar infiltrates like you might see with aspiration. The presence of B lines can also coincide with a number of other disease processes, including, but not limited to, cardiogenic and non-cardiogenic pulmonary edema, pulmonary contusions, and pulmonary hemorrhage. If Frankie's B lines had been seen in conjunction with an increased left atria to aorta ratio, or LAAO ratio size, an increased vertebral heart score, and the presence of a heart murmur, this would have been more suggestive of an underlying cardiomyopathy and possible congestive heart failure. In fact, greater than 3 B lines present at greater than one site is 78.8% sensitive and specific for the presence of congestive heart failure. Let's take a moment now to talk about some stabilization options for Frankie. The initial main goal is going to be calming him down and breaking the cycle of anxiety-driven respiratory distress that he's experiencing. We can do this by starting with a light sedative medication like butorphanol at a low dose, say 0.1 to 0.2 mg per kg, intramuscularly or intravenously, and keeping him in oxygen with patient handling only executed if absolutely necessary. We could also consider an anti-inflammatory dose of a steroid medication, such as dexamethasone sodium phosphate, to help reduce regional inflammation around the airway. For Frankie, given that we're concerned for aspiration into his right middle lung lobe, we could also start a broad-spectrum antibiotic medication such as Unison or azithromycin. It's likely that Frankie may need tracheal stenting in the future. Therefore, if you have the option, a medicine consult would be a great idea here. We also want to complete the remainder of his workup with complete blood work and a blood pressure. Now, let's say Frankie had been a cat with respiratory distress and open mouth breathing. On this physical examination, lung sounds are dull bilaterally, there's no heart murmur, the heart rate is 140 beats per minute, and the body temperature is low at 97 degrees Fahrenheit. Flow by oxygen is provided and the cat stabilizes enough to grab a focused ultrasound examination showing marked pleural effusion or fluid around the lungs bilaterally. Take a moment and think about what your differentials might be. Got them? Some differentials that we could consider for this case are congestive heart failure, chylothorax, pyothorax, hemorrhage, neoplasia, and lung lobe torsion. Now we want to talk about some additional diagnostic steps. While it might be tempting to go straight for thoracic radiographs in a patient like this, your images are likely to be of low yield given the volume of effusion present in the chest. Therefore, it would be recommended to perform a diagnostic and therapeutic thoracocentesis prior to getting your x-rays. The other benefit of tapping the chest first is that cats in respiratory distress are very, very fragile creatures. If you try to take this kiddo and restrain them for the thoracic radiographs, you increase their risk of developing cardiac or pulmonary respiratory arrest. Once the fluid is removed from the chest, you'll have a much better chance of being able to evaluate for things like masses in the chest, abnormal positioning or structure of the lungs, and changes in the cardiac silhouette to better determine the cause for this kitty's fluid. Of course, the composition of the fluid itself is likely also going to be very helpful. Let's say we tap this kitty and we pull off 200 mils of a serosanguinous transudate from the chest, and the radiographs show normal structure of the lungs with no obvious masses present, possible myocardiomegaly, and a normal chest wall. What is an additional test that we could do to help further determine if this kitty cat might have underlying heart disease? If you said look at cardiac biomarkers, you'd be right. NT-proBNP is a point-of-care test that we can do on plasma, or a 1-to-1 dilution of saline and pleural fluid that's used to discriminate cardiac from non-cardiac etiologies of respiratory distress. It has a 93.9% sensitivity and 72.2% specificity for the diagnosis of CHF, which makes it more sensitive than a point-of-care ultrasound and less dependent on the experience level of the clinician. Now, once you're more experienced with the ultrasound probe, you can also look at the ratio of the left atria to aorta diameter, or LAAO, to evaluate for the presence of cardiac disease. A maximal left atrial dimension and long axis of greater than 16.5 millimeters, or an LAAO of greater than 1.5, supports significant cardiac disease. Last but not least, we want to get an ECG on this kitty cat to evaluate the bradycardia that is present. This is true of any patient with abnormal bradycardia or tachycardia to rule out underlying arrhythmias. For bradycardia specifically, we want to rule out AV block and other bradyarrhythmias. For tachycardia, we want to rule out life-threatening ventricular arrhythmias, the most common being accelerated idioventricular arrhythmia and ventricular tachycardia. Accelerated idioventricular arrhythmia, or AIVR, is a ventricular arrhythmia that is not fast and usually occurs secondary to systemic diseases such as shock, metabolic derangements, and physical disruptions of the cardiac myocytes, like with trauma. Ventricular tachycardia, with a heart rate of greater than 200 to 220 beats per minute, should be treated based on the patient's hemodynamic status. If the patient is hemodynamically stable and alert/responsive, immediate termination of the tachycardia may not be necessary. For example, boxers that have historic AIVR live for long periods of time with an accelerated ventricular arrhythmia or ventricular tachycardia. However, for most patients, treatment with an antiarrhythmic such as the sodium channel blocking medication lidocaine is recommended. Lidocaine is the first medication that we recommend when we're talking about treating ventricular tachycardia. As I stated, it's a sodium channel blocking medication primarily. It's used in doses of 2 mg per kg given as boluses up to 8 mg per kg to try to control a ventricular arrhythmia before it progresses to ventricular fibrillation. If lidocaine isn't working, we can reach for amiodarone, which is another antiarrhythmic medication. The biggest con of amiodarone is that it does have the potential for anaphylaxis, so it should only be used if treating with lidocaine or procainamide has been unsuccessful. You can also try treating with magnesium sulfate, an electrolyte that's very important for cardiac myocytes to work properly. It can be given as a bolus and then on a CRI to see if there's any response. If lidocaine, procainamide, amiodarone, and magnesium sulfate aren't working, and the patient has been evaluated by a cardiologist, and you've ruled out other causes of ventricular tachycardia, such as really bad dehydration, it is potentially recommended at that point to talk about cardiac conversion. But you should definitely chat with the cardiologist before pursuing this. Let's shift our focus a little bit and talk about managing and stabilizing the patient in shock. First, let's review what shock means. Shock is a state of inadequate cellular energy production that most commonly occurs secondary to poor tissue perfusion from low or unevenly distributed blood flow, leading to a critical decrease in tissue oxygen delivery. Severe imbalances between oxygen supply and demand lead to inadequate cellular energy production, cellular death, and multi-organ failure. Shock most commonly occurs secondary to poor tissue perfusion from low or unevenly distributed blood flow that causes a critical decrease in oxygen delivery relative to oxygen consumption. There are a few different types of shock. Hypovolemic means a decrease in overall circulating blood volume. Distributive shock is a marked decrease or increase in systemic vascular resistance or maldistribution of blood. Cardiogenic shock is just like it sounds. It usually has to do with decrease in forward flow of blood from the heart itself. Obstructive shock is reduced diastolic filling and preload at the level of the heart. Hypoxic shock is decreased oxygen content in arterial blood, and metabolic shock means that there are alterations in cellular mechanics leading to metabolic dysfunction such as low blood sugar. Basically, the cells are kind of broken down. When thinking about the treatment of shock, for all types of shock excluding cardiogenic, the most recommended initial treatment is going to be administration of intravenous fluids to restore an effective circulating volume and tissue perfusion. This means we need to think about how we're going to administer our IV fluids and what type of IV fluid we're going to give our patient. So first and foremost, let's pick an IV catheter. There are 4 main types of IV catheters out there. One, which is pretty commonly thought of as the butterfly catheter, is truly a winged butterfly needle with a long plastic tubing attached to it. The next is the most common type of IV catheter that you're used to seeing. It's an over-the-needle catheter. It's usually your standard day-to-day catheter that you're going to put into a patient. Third is your through-the-needle catheter. These are longer, usually about 8 to 12 inches, than over-the-needle catheters and come in a variety of diameters. They're usually used in central veins or peripherally in the medial or lateral saphenous veins. Once the catheter is placed and the needle is withdrawn from the skin puncture site, it is either removed completely or covered with a needle guard. These are commonly called PICC catheters or peripheral indwelling catheters. Last but not least, we have our multi-lumen catheter, aka the standard central line. When thinking about our catheter for a patient that we're delivering IV fluids to in a state of shock, we want to consider the size and length of the catheter. It's usually dependent on the goal for the patient. The Hagen-Poiseuille law states that flow is related to viscosity of the fluid, the pressure gradient across the tubing, and the length/diameter of the tubing. This means that maximum flow of an intravenous solution will be obtained by using the shortest length and largest gauge catheter present. Therefore, if you have a patient that's severely dehydrated and hypotensive, needing large volumes of fluid quickly, choose the shortest and largest catheter present. However, if the patient is requiring a decreased volume of fluid over a longer period of time, a longer catheter with a smaller catheter to vein ratio is considered more vein-friendly. The new Kruuse line of safe vet products allows you to carry out infusion procedures with a reduced risk for needle stick injuries, contamination, disconnection, and phlebitis. In short, the Kruuse Safe Vet products ensure safe working conditions for vets and technicians while providing optimal care for some of your most fragile patients. So let's say you have a patient come through the door that has a several-day history of severe vomiting and diarrhea. The patient is listless and laterally recumbent with a heart rate of 160 beats per minute and poor peripheral pulses. You attempt to obtain a blood pressure on the patient and only get a BP of approximately 60 millimeters of mercury. This patient needs IV fluids quickly. So, based on what we just talked about, what type of catheter would you want to use for this patient? If you said a short, large gauge catheter appropriate for the patient size, you would be correct. Let's talk about placement of that catheter. Regardless of the type of catheter you choose, you first want to clip and sterilely prep the area for the catheter placement. For through-the-needle indwelling catheters or multi-lumen catheters like your central line, you'll also want to sterilely drape the area and wear sterile gloves during placement. Once your catheter is in place, you can start your fluids. Balanced crystalloids such as lactated Ringer's fluid, shortly called LRS, and Normazole R are the mainstay of therapy for shock. They contain electrolytes in concentrations that are very similar to what we have circulating in our bloodstream. They also contain agents like lactic acid and acetic acid that help to buffer out increased acid within the blood itself. Balanced crystalloids can be administered rapidly and titrated up to 1 blood volume, 90 ml per kg per dog, and 50 ml per kg per cat, starting with a bolus of 10 to 20 ml per kg, administered over 15 to 30 minutes and monitored for response. Additional fluid therapy options for patients with complicated shock include hypertonic saline, blood products such as whole blood, fresh frozen plasma, and packed red blood cells. Albumin and colloids can be used. Hypertonic saline is most commonly used in either a 3%, 7%, or 7.5% solution, starting at 3 to 5 ml per kg, given over 10 to 20 minutes. Blood products can be administered in patients that are bleeding or severely anemic and hypovolemic at the same time. So if you have a patient come in that was hit by a car, say, and you suspect that they have had a large volume of bleeding either into the peritoneal space or through an external wound, and the PCV is low, you could give them fresh whole blood plus or minus fresh frozen plasma as part of their treatment plan. Albumin is another type of blood product, which is a protein that can be used in patients that are hypovolemic and hypoalbuminemic or suspected to rapidly become hypoalbuminemic. These include patients that are being presented for things like septic shock or perforated bowel. The use of albumin used to be controversial due to only human albumin being available. However, now that there is a lyophilized canine albumin version that can be used and is relatively safe, it's much more common practice to use albumin these days. Another controversial fluid choice is synthetic colloids. Given documented acute kidney injury in humans and documented coagulation abnormalities in animals. Therefore, these have typically fallen out of favor in many emergency hospitals, and it is recommended to use them with extreme caution and only for the appropriate patient population. This might include a dog or a cat that has historic protein-losing nephropathy and very low protein levels that also needs fluid resuscitation at the same time. This concludes our module on cardiovascular and respiratory emergencies. Please proceed to the next module. Thank you.